Good morning, respected seniors. I am here to present my learning class on the topic Deep Learning Model of Primary Tumor and Metastatic Cervical Lymph Nodes from CT scans for outcome prediction in oropharyngeal cancer. These are my contents. Oropharyngeal carcinomas and its link to HPV. Over 95% of these tumors are squamous cell carcinomas originating from the epithelial lining of oropharyngeal mucosa. Traditionally, tobacco and alcohol use were the predominant risk factors. However, over the past few decades, there has been a dramatic rise in HPV-associated PSCC, particularly driven by high-risk HPV-16. In fact, in many developed countries, HPV-positive PSCC has now surpassed cervical cancer as the most common HPV-related malignancy. Basically, human papillomavirus, it is non-enveloped virus which is encapsulated by protein L1 restricted cell. Okay. We're recording this. Good morning, Director Sir. I'm here to present my journal club on the topic Deep Learning Model of Primary Tumor and Metastatic Cervical Lymph Nodes from 3D scans for outcome predictions in oropharyngeal cancer. Here are contents. Oropharyngeal carcinomas and its link to HPV. Over 95% of these tumors are squamous cell carcinomas originating from the epithelial lining of oropharyngeal mucosa. Traditionally, tobacco and alcohol use were the predominant risk factors. However, over the past few decades, there has been a dramatic rise in HPV-associated UPSCC, particularly driven by high-risk HPV-16. In fact, in many developed countries, HPV-positive OPSCC has now surpassed cervical cancer as the most common HPV-related malignancy. Human papillomavirus, it is non-enveloped virus which is covered by L1, L2 proteins in which there is DNA inside which goes into the host cells to infect. HPV. Human papillomavirus infects epithelial tissues of cervix, oropharynx, oral cavity, and anogenital tract. Among its genotypes, HPV-16 is most prevalent in the oral and oropharyngeal mucosa and is the leading cause of oropharyngeal squamous cell carcinomas. Transmission routes include oral genital, and oral anal contact, with high risk linked to a greater number of lifetime sexual partners. Perinatal transmission is also possible through the placenta, birth canal, or breast milk. This is one of the articles I've seen, and I've extracted something from this that it was predicted that PSCC would surpass cervical cancer to become the most common HPV malignancy in the United States by 2020. This occurred in 2012. In the United Kingdom, HPV positive OPSCC surpassed cervical cancer in 2016. Similarly, trends were observed in European countries, including Germany, Sweden, and Denmark. Despite improved survival challenges, there are the lack of identifiable pre-malignant lesions. Poor understanding is there of the natural history of HPV persistence, the need for reliable biomarkers for early detection and prevention. Now let's come to the article. The incidence of P16 OPSCC is rising, especially in younger patients, shifting focus towards post-treatment quality of life. These tumors are often slow growing and may benefit from treatment de-intensification. Here, treatment de-intensification means reducing the dosage of any kind of therapy that is given, for example, chemotherapy, for better prognosis of the treatment. However, previous attempts at de-escalation without proper patient selection have led to worse outcomes. Chemotherapy can cause unnecessary toxicity in patients with low recurrence risk. There is a critical need for better biomarkers to identify truly low risk patients who may not benefit from chemotherapy. Rationale. In P16 P16 positive OPSCC, tumor size and presence of metastatic cervical lymph nodes are well established prognostic markers. These are evaluated using the TNM staging, where T classification shows the size and depth of invasion of the primary tumor, and N classification shows the number and size of metastatic cervical lymph nodes. But there are some limitations of TNM staging. While TNM staging helps with risk stratification, it does not capture the internal complexity of the tumors and lymph nodes. It means that it shows how much this tumor is spreading, but still the aggressiveness of the tumor is not able to assessed by TNM staging. With the transition from American Joint Committee of Cancer 7th to 8th edition, nodal classification became even more prognostically important. Here, there is a need for better tools to assess, to characterize nodal involvement in P16 positive UPSCs. Now, what is the role of imaging and artificial intelligence? CT imaging is already widely used to assess prognosis and treatment response. The interaction between the primary tumor and metastatic lymph nodes create unique patterns on the imaging. Deep learning algorithms can identify these subtle imaging features to predict clinical outcomes. While several studies have focused on AI-based analysis of primary tumor, there has been less attention has been paid to evaluate both primary tumor and lymph nodes together. Primary tumor has been assessed by, there are many articles that have been given by AI, like primary tumor can be assessed, but both the relationship between the primary tumor and lymph nodes is still a question mark. Study aim. This study developed and validated a novel CT-based imaging risk score called SWIN score to predict outcomes in P16 plus OPSCC. SWIN score is a kind of AI tool that has been used over here. Methodology. SWIN score was developed using hierarchical vision transformer model, SWIN transformer V2.0 by Microsoft. The model extracts and integrates features from primary tumor and metastatic cervical lymph nodes. These features are combined using cross-region self-attention, allowing the model to better understand the interaction between the tumor and the lymph node characteristics. Let's come to the methods. Study population. This was a retrospective study including a total of 811 patients with P16 positive oropharyngeal squamous cell carcinoma. From 3 different sources, patients were extracted. The Cancer Imaging Archive, TCIA, 522 patients. It included 5 public data sets like OPC radiomics, head and neck squamous cell carcinomas, 134, head and neck PET CT, 51, head and neck radiomics, head and neck 1, and TCGA 22. Data were collected between 1998 and 2013. Cleveland Clinic Foundation, 233 patients were there, and Winship Cancer Institute, 56 patients. Now, study design and groups. Tripod guidelines were used, which ensured transparency in prediction model research. Patients were divided into 3 data sets. Data 1, training set, which had 452 patients from TCIA, 86.6%. D2, internal validation set, it had 70 patients from TCIA, 13.4%. D3, external test set, 289 patients from CCA plus Winship. Now, CT imaging and pre-processing. All patients underwent baseline CT scan before the treatment or without contrast. Manual segmentation of the primary tumor and lymph node was done using 3D slicer software. Dental artifacts such as if any dental metallic filling is there or braces are present, they all were excluded. Deep learning model, architecture, training and evaluation. Model design. The authors used a hierarchical vision transformer, this SWIN transformer, to build their deep learning model. This architecture was chosen because it captured both the local feature, the small, what all small changes were there in the tumor structure, or global patterns, or what any kind of relationship with tumor or lymph node. Feature extraction. The model looked at two cancer regions, primary tumor and metastatic cervical lymph nodes. It processes them separately using four transformer blocks for each region. It uses a technique called self-attention to allow the model to learn interaction between the primary tumors and lymph nodes, like how their features might influence each other. Risk score output. The model was trained to predict the 3-year disease-free survival. It produces a continuous risk score called as win score. If the score is greater than 0.5, the patient was classified as high risk. If the score is less than 0.5, the patient was considered low risk. Now let's come to the training method. The model was trained end-to-end using a common technique called binary cost entropy loss, which was used as in the model for improving its prediction accuracy. The outcome label was whether the patient remained disease-free at 3 years. Now let's come to stats. Statistical analysis was conducted between February and July 2024. All analysis was done using R software version 3.4.0. Basic group comparisons were done to compare differences in age, smoking, pack years, and SWINS score cross groups. One-way ANOVA was used for continuous variables, and chi-square test was used for categorical variables. Basically, chi-square test is used to assess the relationships between, it can be two groups, gender, stage, etc. Model performance, survival prediction. Harris C index was used to measure how well the model predicted survival outcomes. Harris C index is Harris concordance index. Patients were split into high and low risk groups using the median SPIN score from the training set. Kaplan-Meier curves were plotted to compare survival between these risk groups. These analyses were also repeated with each AJCC stage group to assess how SWIN score performed across early and advanced cancers. Now, feature importance and interpretability. Sharp values were used for it. It is one of the tools to assess the for predicting the outcomes. Results were shown using a B-swarm plot, helpful for visual interpretation. Integrated gradients were used to highlight which areas of the tumor and lymph node influence the model's prediction the most. Helps improve the model transparency. Biological correlation. Model's internal features were correlated in the gene expression data in patients from TCGA to understand the biological relevance. The chemotherapy benefit and interaction analysis was done using a Cox regression model. This tested whether chemotherapy benefit differed from high and low risk groups based on SWIN score. Its significance showed all were considered statistically significant at p more than 0.5. Now results. I'll simplify this table over here. Total patients 801 were taken. Training set 452 were taken. Internal validation 70 and external test set 218. Gender male was 683 patients, 84.2%. Female 128 patients, 15.8%. Median age was taken 59 years. Cancer stage breakdown according to AJCC 8th edition. Stage 1 24.5%, stage 2 53.7%, stage 3 24.8%. Now the treatment. 74.2% received chemoradiotherapy, whereas 25.8% received radiotherapy alone. Follow-up period, median of 65.9 months was taken. Events observed, disease-free survival, 22 events, 2 events, and overall survival, 177 events, whereas local regional failure was 64 events. Performance of SWIN score, multi-region imaging risk score. Risk stratification. Patients were divided into high risk and low risk, based on a SWIN score cutoff of 0.5 determined from the training set. This same cutoff was applied to validation and test sets for consistency. Here we can see hazard ratio is more than 1 in all DFS, OS, and LRF. P value is significantly same over here, and C index is 0.63. That is almost same in DFS, OS, and LRF. It interpreted that higher SWIN score was strongly associated with poorer outcomes. Now, stage-wise subgrouping analysis. Stage 1. SWIN score significantly predicted DFS, OS, and LRF. Stage 2. No significant risk separation was observed. Stage 3. Significant separation for DFS and OS. The multi-region risk score and independent predictor multivariate Cox regression analysis was performed. The multi-region imaging risk score was a strong independent predictor of outcomes. DFS hazard ratio was 2.08, whereas in overall survival, hazard ratio was 3.58. Sharp analysis ranked this score as the most variable in the model. Here we can see Kaplan-Meier graphs. There are 4 graphs over here presented. It is showing that in A, survival probability, first of all, the blue line is showing the chemo therapy, and the orange line is showing the chemoradiotherapy. Yes, sorry. Blue line is showing the low score, and the orange line is showing the higher score. So in all the 4 graphs, we are seeing variability. Now I'll discuss the table 2, multivariable Cox proportional hazards regression analysis. Smoking, more pack years equals to worse survival. T4 stage advanced tumor, high risk of death was there. In older age, slightly worse overall survival. High imaging risk score strongly predicts worse outcomes. Tumor in posterior pharyngeal wall, soft palate, worse disease-free survival was there. Different risk scores used created 3 types of risk scores from CT images. SWIN primary tumor used data from the primary tumor only. SWIN lymph node used data from the lymph nodes only. Multi-region scores combined both primary tumor and lymph node data. These were used to predict chances of recurrence, survival, and local treatment failure. Prediction accuracy results. The multi-region risk score gave the best results for predicting disease-free survival and overall survival. For predicting the local or regional failure, the SWIN PT score did slightly better. This means tumor information was more useful for local control, and lymph node data added more value for predicting the survival. Model focus areas. The AI model focused mainly on the tumor and lymph node regions on the CT. This matches what doctors usually look at, showing the model's focus is accurate and relevant. Relationship with clinical factors. The imaging risk scores were compared with the clinical data, like T and N stage. The results showed good correlation, meaning the scores are linked with known clinical risk factors. Now let's come to the discussion part. The challenge in P16 OPSCC. Patients with P16 positive oropharyngeal squamous cell carcinomas generally have good survival outcomes. Because of this, oncologists are trying to reduce the intensity of the treatment, whether it is radiation or chemotherapy, to avoid long term side effects. But not all low stage patients behave the same. Some relapses or develop metastasis even after de escalated treatment. So, current clinical tool like AGCC staging may not be enough to personalize the therapy. Need for better stratification. Trials like NRG HN002 used standard clinical features to identify low risk patients, but some of these low risk patients still had treatment failures. This shows the urgent need for better biomarkers that can guide us more precisely on who needs full treatment and who can safely receive the less. So we know the aim of the study was uh, it developed a CD-based multi-region imaging risk score using deep learning. It combined imaging features from both primary tumor and metastatic cervical. The aim was to predict survival outcomes and help personalized treatment decisions for P16 positive OPSCC patients. Key results were the risk score could clearly divide patients into high and low risk group for survival. It remained an independent prognostic marker for disease free survival and overall survival, even after adjusting for clinical stage and other variables. Even within AGCT stage 1 patient, the score could identify those with higher risk who might benefit from full or intensified treatment. What makes this model unique? Older models focus only on the tumor or use basic ways to immerse the data. This model used self-attention or hierarchical vision transformer automatically quantify patterns in both tumor and lymph nodes, understand the interaction between the two. This deep learning approach allows more meaningful and accurate risk prediction. Importance of lymph nodes. Lymph node imaging features improve the prediction of disease-free survival and overall survival, but did not improve the prediction of local regional failure. Suggests that lymph node status is most linked to overall survival than local disease control. This insight could help us refine which features to use for different treatment decisions. Predictive value in stage 1 and stage 2. In stage 1 patients, those with high risk scores benefited from chemotherapy. In low risk patients, the addition of chemotherapy made no major difference. In stage 2 patients, the same trend was observed, but it wasn't statistically significant. So the model is most reliable in stage 1 and could guide treatment de-intensification safely. Okay, so here we have a CT scan. The bar graph over here shows the distribution. High risk scores means worse predicted prognosis, whereas low risk scores means better prognosis. Patient over here are grouped from high to low scores. We can see over here there is a cutoff line present which separate the low and high risk groups. Middle and right for 4 sample patients A to D. It is shown over here. Highlighted areas in primary tumor and lymph nodes. Uh, Yellow line is for the primary tumor and the lymph nodes. It is the red line. The model does not just give a score. It visually showing which tumor lymph node refers influence the score. So here's another graph, Kaplan-Meier survival graph. Here we have the predictions for chemotherapy and chemoradiotherapy. We can see 4 sets of graphs over here, survival graphs over here. In graph A, we can see chemoradiotherapy. The radiotherapy depicts the line yellow, and the chemoradiotherapy depicts the line over here is blue. We can see the changes in A and C. But we can see in B and D, there are not much changes and improvement of the disease. Clinical relevance and future use. If validated further, this imaging risk score can guide precision therapy, reduce toxic treatment for low risk patients, ensure high risk patients do not get undertreated. It bridges the gap between the imaging AI and clinical oncology. It may play a major role in future personalized treatment planning. Now, here we have study limitations. Deep learning is hard to interpret. The AI model used deep learning, which works well, but does not clearly tell us why it is making certain predictions. In contrast, traditional radiomics uses specific measurable features like tumor size, shape, texture that are easier for the doctors to understand. So this model is basically a black box which can make it harder to trust without deeper insight. Only largest lymph nodes were assessed. For each patient, only the large metastatic cervical lymph nodes were included in the analysis. But patients can have several nodes involved, and smaller ones might still carry important clues about the prognosis. The model may have missed some useful information by ignoring these. Retrospective study, risk of bias. This study looked back at existing data instead of running a new controlled clinical trial. Because of this, important factors like radiation dose or the type of chemotherapy patients received were not standardized. That means different patients got different treatment which could effectively bias the treatment and results. Missing detailed treatment information in data sets. The data used in D1 and D2 didn't contain complete information about the type, dose, or schedule of the radiation and chemotherapy. This makes it unclear if the model would work equally well in the settings where treatment protocols are consistent and carefully followed. Not strong enough evidence yet, this study gives us early clues but not the final answers. It suggests the imaging risk score might help identify the patients who benefit more from chemotherapy, but more studies are required before we can use it in our daily practice. I'll come to the conclusion. This study has introduced a multi-region imaging risk score based on CT scans that effectively stratifies risk in P16 positive OPSCC by analyzing both primary tumor and metastatic lymph nodes. It not only predicts survival outcomes but also shows potential in identifying which early stage patients may benefit from chemotherapy. With further validation, this tool could help personalize treatment, reduce the overtreatment, and enhance the clinical decision making in HPV associated oropharyngeal cancers. In a nutshell, I'll just sum up. This study demonstrated that a CT-based deep learning model combining primary tumor and lymph node features can significantly enhance the prognostic accuracy in HPV positive oropharyngeal cancer. As AI becomes increasingly integrated into radiology and oncology workflows, such tools hold promise for guiding more personalized and effective cancer care.